A crashing patient in the emergency department presents as a cascade of macroscopic failures. Blood pressure drops, oxygen saturation plummets, and the neurological baseline rapidly deteriorates. At the molecular level, these disruptions follow a highly ordered biochemical logic. In acute medical toxicology, systemic collapse follows a pattern of highly specific receptor-level interference. A xenobiotic, a foreign chemical substance, binds to a target and forces an abnormal physiological response. The clinical toxicologist reverse engineers this chaos. By observing the ambiguous macroscopic symptoms at the bedside, they trace the physiological pathway backward to identify the microscopic mechanism causing the disruption. Decoding organ-specific biomarkers across the cardiovascular, respiratory, hematologic, and neurosensory systems allow clinicians to identify the mechanism and likely chemical class involved. This mapping enables them to sequence targeted interventions and intercept the toxicity before end-organ failure occurs. The 12-lead electrocardiogram provides the most immediate clinical window into toxicological ion channel disruption. It translates microscopic electrolyte shifts into a macroscopic geometric readout. This graph aligns a cardiac cell's action potential with an ECG complex. Phase 0, the sharp vertical spike, represents sodium-driven depolarization. Xenobiotics like cocaine directly block these sodium channels. Consequently, intraventricular conduction slows, physically stretching the waveform, manifesting as a prolonged QRS complex. This diagram shows how delayed conduction specifically pulls the electrical vector of the heart. As the right ventricle struggles to depolarize, the terminal axis shifts rightward, directing a prominent terminal R wave toward lead AVR. Repolarization carries its own distinct vulnerability. During phase 3 of the action potential, potassium must exit the cell to reset the electrical gradient. Agents that inhibit this potassium efflux delay repolarization, stretching the T wave outward. This prolonged QTC interval creates a critical instability, leaving the myocardium vulnerable to early after depolarizations, known as the R-on-T phenomenon, which triggers the dysrhythmia torsades des points. Beyond electrical conduction, the heart is vulnerable to direct mechanical suppression. Calcium channel blockers and beta-adrenergic antagonists reduce myocardial contractility, or inotropy, leading to severe cardiogenic shock even when the electrical rhythm appears organized. Widened QRS complexes and prolonged QTC intervals provide direct, quantifiable readouts of cellular sodium and potassium failure, leading to cardiogenic shock. Respiratory toxicity splits into two distinct pathways: the neurological drive to ventilate and the hematologic capacity to deliver oxygen. A failing respiratory system presents as either profound ventilatory depression originating in the central nervous system, or as a compensatory hypnea, where the patient breathes deeper and faster to clear a toxic byproduct. This image outlines the slow mnemonic, detailing the most common xenobiotics responsible for severe hypoventilation. Sedative hypnotics, liquor, opiates, and weed all act as central nervous system depressants, blunting the medullary response to rising carbon dioxide levels. Conversely, this list shows the PANTS mnemonic for hyperventilation. Salicylates, like aspirin, cause a profound metabolic acidosis. The body responds with a rapid reflexive hypnea, an attempt to exhale carbon dioxide and artificially raise the blood pH to survive the acidemia. A patient can have a perfect ventilatory drive, breathing deeply and regularly, and still suffer from fatal systemic hypoxia. This occurs when xenobiotics attack the hematologic delivery system. Hemoglobin relies on cooperativity, conformational shifts in the molecule that allow it to pick up oxygen in the lungs and easily release it into the tissues. Xenobiotics like carbon monoxide or methemoglobin inducers disrupt this mechanism by altering the hemoglobin's configuration. This chart maps the oxygen-hemoglobin dissociation curve. At 45% carboxyhemoglobin, the curve shifts left. Remaining functional hemoglobin binds oxygen with such high affinity it refuses to release it. Because oxygen remains locked to the tetramer, measured partial pressure reads normal. The patient undergoes cellular asphyxiation. A normal pulse oximeter reading provides a deadly illusion if the clinical toxicologist has not accounted for xenobiotic-induced shifts in the oxygenation curve. CNS toxicity is driven by the balance of inhibitory GABA and excitatory NMDA pathways. Chronic alcohol use forces the brain to downregulate GABA and upregulate NMDA. Removing alcohol floods the brain with unopposed NMDA excitation, triggering autonomic excitability, severe psychomotor agitation, and withdrawal seizures. Organic chlorines execute different attack vectors, acting directly as GABA antagonists. By severing these inhibitory brakes, the nervous system hyperpolarizes into unchecked repetitive neuronal discharges. Clinicians quantify this invisible, fluctuating neuroderangement using standardized tools like the Richmond Agitation Sedation Scale, or RASS, and the 4-score. This graph displays the ROC curve for the RASS sedation score. By mapping sensitivity against specificity, toxicologists use this data to predict the exact threshold where a patient's airway reflexes will fail, making endotracheal intubation mandatory. Specialized sensory organs offer specific early warning signs before total collapse. Pupillary miosis or mydriasis pinpoint precise cholinergic or anticholinergic toxidromes. Acute tinnitus, a ringing in the ears, signals cyclooxygenase inhibition and altered cochlear blood flow, a hallmark of salicylate poisoning. Agitation trajectories and isolated sensory deficits operate as precise mathematical and physiological precursors to total airway collapse. The cardiovascular, respiratory, and neurological systems do not fail in isolation. In the poisoned patient, their interconnected derangements form a unified diagnostic matrix. A widened QRS interval, a left-shifted oxygen dissociation curve, acute ototoxicity, and a plunging RASC score act as hard variables. When combined, these variables unmask the molecular identity of the ingested poison. This flowchart illustrates the strength of recommendation algorithm for extracorporeal treatments. Toxicologists map clinical data against these pathways to authorize invasive procedures like hemodialysis. Relying on these consensus matrices justifies the rapid deployment of mechanical filtration well before the patient reaches an irreversible state. Advanced toxicology uses organ-specific biomarkers to intercept xenobiotic toxicity at the cellular level. It's the science of stopping the collapse from the inside out.